Dr. Yoku. So I'm called Dr. Batte Anthony. Usually when you're almost the last presenter, everyone is a bit tired and the brain is full. However, what I want to tell you is about malaria and AKI and children, and also to tell you that not everyone with AKI dies. So in the dialysis unit of Dr. Chigundu, many children, many adults have survived, even though for some reason our presenters picked those who died. So please, when you go out there, mark the nephrologists as those that make people survive. And when you see AKI, don't think. And remember the sessions where the children just died or the adults just died. But they told us, like one of the presenters said, we should declare whether we are going to benefit from this or not. So there's no conflict of interest in this presentation. So the question is, how big is the problem of malaria and AKI in children and adolescents, like the 17-year-old that was presented? What we know is, from the studies that have been done so far in Morocco, one of the studies followed very many children, 652 children, and it was clear that AKI was in 35.1% children who had been admitted. You can see that that is a third of every child who is admitted with malaria as AKI. Was this produced again in another study? Yes. Another study again done in children 6 to 5 years, recently still in Morocco, still showing the same thing, that malaria and AKI are almost together. 50% of the children will have the malaria and develop AKI. The interesting part, why you are now asking, is the dialysis unit now full of the children? Because half get the AKI. Not everyone dies. But what we know for sure, even the AKI for which you want to require dialysis, or AKI, the moment there is AKI in that child, the chances that that child will die are higher than when the person does not have malaria. Does not have AKI. And from so far the one small case or two cases that you've seen, when there is malaria and there is AKI, the risk of death is really high. And this is what these two studies demonstrate. And it wasn't a problem of only the hospital. So another study still among children in Ginger Hospital, about 180 children, still followed up. But this was a bit some years ago, about, I think much of this was 2011 to 2013, and this was another CT for which they were examining the role of inhaled nitric oxide in treatment of cerebral malaria. However, at some point when secondary analysis of the data was done, it was still seen that mortality goes up to 37.5%. And this was in the group that was receiving the placebo. Therefore, malaria, you get it, please look at how much urine is being passed and check the creatinine as well, because it is a risk. And this, like I've said, is not only a problem of children. It is a problem also in adults. Now, there is this review that has just been produced recently, last year, trying to check up, is this the same thing that is being replicated in every other part of Africa and the world at large? And you can see that actually here, uremia is a bigger cause of mortality, which is comparable to when a child comes with unconsciousness or coma. The same way they come with acidosis. All these three things contribute to a big percentage of mortality, both in adults and the children. Still, another systematic review. This was also interesting because for the first time, I should say, I think now the eyes are opening up for AKI and malaria. This is a publication that has just come out about 2 years ago, and it was trying to review all the studies that have been carried out on malaria, AKI, and other laboratory predictors of mortality in African setting, especially African children. And you could see, you may not see the odds ratio, but the odd of renal failure is around there, almost 6. So AKI, or renal failure, can be a leading cause of death more than even coma. So you may think this is cerebral malaria, or the unconscious child has died because of cerebral malaria, but there are high chances this was because there was AKI. So AKI can actually be may actually be the leading cause of death in our settings when we are treating malaria. And that's showing the odds that we can see. So, but what exactly happens? Why should malaria cause AKI? Is there any evidence that tells us clearly what exactly is happening? And so, what we know is, or what we see in practice, even during our practice, sometimes we have the children who come and they just have AKI plus the malaria. Sometimes it comes as part of other organ failures that are happening in the same person. I think like the first patient that was presented, the liver, the heart, the lungs, and the kidney become just part of the many organs that are being failed by malaria. And as well, we know volume is very important. It's high likely that to some degree, the leading cause of why children or adults have AKI could be because when they get malaria, they stop eating, they stop drinking, then they have vomiting and they have diarrhea. So the low volumes, for sure, no one asks or should question that. But then the question of nitric oxide, cytokines, vasodilatation, something to mimic what happens exactly in sepsis, I think is not questionable, and it is clear that this is also one of the ways in which we should explain what happens in malaria. Then, even the resistance to the vasoactive hormones because of the hypoxia that will happen following the cytoadherence and the rosetting. Probably these are all factors that come together, sometimes come individually in one patient, and they contribute to malaria, AKI. There is this kind of, this chart that I got in one of the reviews, which I thought is pretty nice in explaining or giving a rough idea of what exactly really happens. I think you can tell that most likely not one mechanism should explain malaria AKI. And even in practice, for sure it can't be one mechanism. Some patients are not swollen, they just have AKI, or they are dehydrated and have AKI, for sure, some group. Some group comes and they are well hydrated, they have volumes, but they have AKI. Others, you just can't tell. In fact, some even come walking in and when you check, creatinine is starting to rise. So, most likely we have the idea of sequestration of red blood cells, which are parasitized, that is the PRBC, which causes the hypoxia and then start off the cascade, including the hypoxic effects of hypoxia, especially to the small venues or the small capillary. Then the idea of hypovolemia, which for sure, when the volumes are low, then there is sympathetic response and the RAS, all that, there is poor perfusion. And then the last one is how the immune response really comes in to influence whatever happens. Either the reactive oxidative intermediates, the oxidative stress, nitric oxide, whether it is protective or not protective, we are not yet sure, and how this can cause the vasodilatation. Remember, this vasodilatation, even in the setting of sepsis, sometimes it is everywhere, but in the organs themselves, they have already activated the RAS, they are activating the vasopressin, causing again poor perfusion, especially the kidneys. Because for them, when the pressures fall, then the kidneys will start reducing the blood supply or causing vasoconstriction in themselves to make sure the blood pressures go up. And then this compromises the blood supply to them, and I think causes AKI. The last part is the role of immune complexes and the glomerular lesion. I won't expound so much on that, but I think we need to think so much about it because I think we've even written a paper about it, about is there a glomerulonephritis in malaria. But I think we don't have clear answers yet. So just to talk about the cytoadherence that happens because of the PFM that comes up and then makes this, which is a protein that is expressed on the red blood cells, makes them sticky, form knobs, then they start adhering to the vessels. Then these cells that are now sticky can get, apart from sticking to vessels and causing hypoxia, again can stick to the normal red blood cells, causing what we call the rosetting. Both these will cause compromised blood supply. And then, like we say, the whole idea of cytokines, I think it is not very clear how exactly these inflammatory cytokines cause the AKI in malaria, but what we know is inflammatory responses sometimes are detrimental, and because malaria is for sure sepsis and usually mimics sepsis, but this I think is very important. But of course, as you know, we also have the drugs that we use, the NSAIDs, the co-infections that come with the malaria, and then all these compound the whole picture. Now there is this new concept, the cell-free hemoglobin. There is, I think, one publication about two now, but one was by Catherine, cell-free hemoglobin, lipid peroxidation, and oxidative stress. I think this sounds very nice. First of all, sounds complicated, right? But sounds very nice in understanding malaria and AKI. We currently are now doing a study to understand this mechanism in sickle cell, but I think we should expound it more and we should read more about it when it comes to how does it influence AKI in malaria. There's this study still talking about cell-free hemoglobin, because what I think is clear is that malaria AKI is not straightforward. I think it is not as simple as hypovolemia and AKI. We should think more, and one of what my theory is, the reason why we have not got to know much about it is because malaria is in our countries that are poor, where we don't do any biopsy, we don't do any immunofluorescence, and therefore we can't describe what exactly is happening. But if it had been in a different setting, we would be exploring a bit more. And I think this is why some of these papers come up handy to stimulate us to want to explore more. Here, one of the studies, this study is showing that when the ratio of cell-free hemoglobin is more than hemopexin. Hemopexin is one of the proteins that are antioxidant to cell-free hemoglobin. When that ratio is high, those children that have a lot more heme in their extravascular space, they are having higher risk. That is the red box. Remember, these are box plots. They have higher risks of AKI. They are the ones that have stage 3 AKI. As the days go by, this starts to level down, but you can tell that there is a role of cell-free hemoglobin in causing AKI. The second chart is also showing how this role of cell-free hemoglobin is influencing the higher levels of urea. But these are all just small highlights to tell us, I think we need to think further than just simply reasoning out malaria AKI to be pre-renal and all that. One of the recent papers that we wrote up, we also found autoantibodies higher and predicting AKI compared to children who didn't develop AKI. This, again, because we are not doing immunofluorescence, we are not doing biopsies, we can only do light microscopy, it limits our reasoning and understanding of malaria AKI. But I think some of these should open our eyes to think further and explain further and to see if we can do something different other than treatment. Now, I'll just go about, I think, 3 slides remaining and I'll be done, I'll leave. So, we go to management. Management of malaria AKI, we should follow the WHO guidelines. There's no question about that. But I think we need to still think further. There's something from our practice, in fact, on our unit, we change a bit. Children, people are coming, they have been on artesunate, yes, it's positive like the first patient. They have the AKI, malaria is worsening, and so what we are doing, we have changed to quinine. One thing is I tried to document many patients and contacted NDA and Ministry of Health. I think they're not buying the idea to think a bit more about this, about treatment guidelines, and to explore it further. Is there something that is happening? I won't go too much in the detail, but what is clear, the study, the landmark study that made our policy to change, WHO based on this Aquamat study, it was in 7 countries in Africa, and they showed clearly that when you use artesunate, there was relatively more death, less death compared to when you use quinine. And that paper went to the Lancet and made us change the policy. However, in that paper, they did not evaluate kidney and liver. They only talked about urea. That's why the charts that I was showing you are showing urea and death. They did not evaluate AKI using the standard. I think that is something that they need to think about as they're changing our policy and how artesunate and quinine, which one influences AKI and which one doesn't. Thank you. So, but still the same management, like Dr. Chibul is going to tell us, is how we manage AKI. Whether it's malaria or what cause, same principle. I don't have to talk much about it. And what we are seeing is still a number of children who survive AKI develop CKD. But like I said, majority of them survive. Even some have gone on to get transplanted. I have so far 2 who have got transplanted because of malaria, AKI, kidney, CKD, transplant. So AKI, malaria can go into CKD. And recently, one of the papers that came out was also showing that it actually can be an independent predictor of neurocognitive defects. So some of our children, if they don't perform well in class, it could be malaria and AKI. So malaria is one of the causes of disease and AKI in our children and in our adults as well, and we need to just be vigilant.
This is, in my opinion, common sense. When you have a severe ill patient with malaria, use a single drug. But when you have basic clinical malaria, you use 2 drugs, isn't it? Which is artesunate, inflammatory, blah, blah. So many people need to think about that. And we partly agree with you because we have treated patients who are severe. And we know that you may have had something on top, but that is for the specialists to think about. Does it really make sense? I don't know.
For severe one, they use one. I think that way I will leave it. I want to also comment on it because it has some. Dr. Batte, but this is very interesting. Dr. Batte.